Anyway, for you guys who don't understand, Nat asked me to show her some chest X-rays because she was getting a bit rusty, and she asked me to teach her something for COVID-19. So I decided we'd have a theme, and the theme would be the Harlequin tube. So this image here is a neonatal skin condition known as Harlequin colour change, and it's a good theme for this tube because no one knows what causes it. But you see it in infants and it goes away, as compared to these two characters, which are harlequins. And if you read the definition of a harlequin, he's an Italian comic character. His role is that of a light-hearted, nimble and astute servant. And I can't read what that next line says.
Often acting to thwart the plans of his master. Oh, geez, right. Bob.
You know what, we've chosen the harlequin. And that's going to remind you to look both ways.
Oh, okay.
Because what I call a harlequin chest X-ray, if you go to the next slide, is an X-ray where one side's white and one side's black. And you have to work out which side's abnormal and why. So the top three are all examples of what I call harlequin chest X-rays, but you can also have checks if you really want on the bottom three. So we can do checks and we can do stripes on whatever you like. So today's theme is the harlequin chest X-ray. So the first four cases are what I call the basics. So off you go, Nat. Here's the first case. It's a 56-year-old lady who's had a stroke.
Okay, so mobile supine X-ray in an adult female patient demonstrates that the patient is intubated with the tip of the ETT lying low within the trachea and a tube that projects from the centre superiorly towards the left side in what I would expect to be the left lower lobe bronchus. The tubes are associated with asymmetric density of the lungs, with the left lung being uniformly white or dense compared to the right side, which I think is normally aerated. There's probably small bilateral pleural effusions, although I think it's hard to tell on the left, and there's no definite pneumothorax within the limitations of a supine film. There is loss. Well, I think there's mediastinal shift to the left because I don't see the right heart border particularly well. So I think the abnormalities on the left, I think there's a pacification of the left hemithorax with associated loss of volume. So I'd be concerned about left lung collapse, particularly in the context of ETT and a probable nasogastric tube going down the wrong orifice.
Right, let's take the tube. So the important thing is it's a white hemithorax, which is small. Mm-hmm. Note the gas under the left hemidiaphragm is probably as high as the right diaphragm. The left ribs are crowded. The mediastinum's shifted to the left. So there's significant volume loss and you've got an opaque hemithorax. Mm-hmm. Now, you said the ET tube was low in the trachea. How low?
It's hard to see exactly where the left main bronchus comes off of, but I'm guessing that's actually in the right main bronchus.
Yep, it's below the left main bronchus, so it's in the right main bronchus. Yep. And that's a classic X-ray of an ET tube in the right main bronchus. Now, the nasogastric tube you said was in the left lower lobe bronchus. How certain are you of that?
I wouldn't bet one of my children's kidneys on it.
If you look carefully,
I'm pretty certain. Okay, so I can see the nasogastric tube up to the level of the left, what I think is the origin of the left main bronchus, which is probably about 1 centimetre from where the ETT ends, and then. If I trace it, so the issue would be that if there's volume loss and if there's shift of the esophagus and the stomach, then could it be in the stomach? So I'm looking for the stomach bubble, which I don't think I can confidently identify where that is. So I would, and that would be a good location for the left lower lobe bronchus. So I would say 80% certain that it's in the left lower lobe bronchus.
Right. Well, it looks like it's in the left lower lobe bronchus.
But
why don't you look at its course?
Well, So that was
in
the
upper chest.
Yeah, I was going to say in the upper chest, it's not.
trachea,
It's lateral to the trachea. That was odd. I did see that, and I thought
higher than that, it goes to the right side of the pharynx.
Correct. Yeah.
Or the right side of the larynx, probably. Really.
Yeah.
So I suspect it's actually not in the left main bronchus, and I suspect it's probably in the esophagus/stomach, and that's just the top gastric fundus is probably up that high, and you can't see it.
Yeah. Okay.
So,
I said 80%.
Small 80%. Okay. So this is a small white hemithorax.
Yep.
Case 1. Next case.
Yep. Okay. So this is, and so do you want me to present it like the registrar
I've
should
got this
present
silly, can I drag this out of the way? The Teams message is sitting over the bottom of my images.
Yes, you should be able to drag that out of the way.
How do you can I drag it?
Yeah, you should be able to.
No, well, not to worry. Oh, man, keep going. It's gone now.
It's gone now? Yeah, okay. So okay. So we'll just restart that bit for the purposes of the recording. Just let me make a note. Case 2.
Yep.
All right, so next case. So did you want me to present this like I would if I was in an exam, Bob? Okay.
Off you go.
Yep, all right.
82-year-old lady, and I've written what was written on the request. That's exactly what it said. There'd been an X-ray earlier that day, and they didn't understand what it showed.
Okay, so erect mobile film in an 81-year-old female patient demonstrates opacification of the left thorax with mediastinal shift to the right. Well, actually, yeah. So yes, I think there is increased volume on the left because I think there is widening of the posterior rib spaces, and I do think that mediastinum is shift, even though she's a bit rotated. The thing that's curious about this one, different to the last one, is that there's this sort of lucency, like a half moon shaped lucency within the left upper zone, without a distinct air fluid level within it per se. Like I can see the superior margin, but I can't see the inferior margin terribly well. The right lung is clear. The right costophrenic angle is clear. I don't see a pneumothorax. And she's had what looks like old trauma of that left clavicle. I think there's an old fracture.
How old is it?
Oh, I'm not certain, to be honest. It looks like the distal margin of the medial portion looks quite tapered. And I think there might be some.
Given that you've noticed it, I'll tell you, she came in 3 days ago, having fallen on the left side.
Okay, all right. Actually, now that you say that, I think there are rib fractures on the left.
And there are rib fractures, and both lungs looked normal 3 days ago.
Right. So, in the context of trauma, we've now got we've got increased opacity with mediastinal shift. So I'd be concerned about a growing effusion in the context of trauma, growing hemothorax. I'd want to know if she's clinically unwell, though I know she doesn't have any oxygenation tubing associated with her, but I'd be concerned.
The typical one of these old trauma patients who get admitted to the medical wards and they did an X-ray follow-up and saw the X-ray looked abnormal, so they did what they usually do. They did another X-ray.
Yep.
So I don't think anyone's actually looked at her to see how well she is.
I don't think this is collapse or consolidation. I'd be concerned about an effusion. In the context of trauma, diaphragmatic rupture, and that lucency is making me concerned that could that be stomach sitting up there?
No, that's just the bit of aerated lung she's got. It's just a large hemothorax. Quite right. Yeah. So this is the whole point of this one as compared to the previous. This is a white hemithorax where there's positive mass effect. Just looking at the two sides, that hemithorax is bigger than the opposite one.
Yeah, yeah. And I have to say, I got a little bit confused at the beginning because it looks like the ribs at the top are quite crowded, but actually when you look at the posterior ribs, they are definitely wider than the contralateral side.
I find seeing rib crowding per se often difficult. Sometimes it isn't.
Yeah.
But I just eyeball which side of the chest is bigger, and I find that an easier way of deciding if there's volume loss or not than anything else.
Yep. Cool.
Right, so this is a big hemothorax.
Yep.
Next case.
Next one. All right. So now we're in the other pattern where the lucency is the abnormality as opposed to the opacity. So we've got a frontal radiograph in a 75-year-old female who's moderately short of breath.
She presented to the emergency department just a bit short of breath, but really not unwell.
Okay. So there is abnormality involving the left hemithorax characterised by lucency compared to the contralateral side with multiple curvilinear densities. The changes are associated with mediastinal shift to the right. There's an interesting lucency projected over the aortic arch. I'm not sure whether that's a more loculated component or whether it's just one of those bands which has remained in situ. I don't see a convincing. I'm not sure where the pleural edge is. So my main differential that I'm trying to exclude here is a tension pneumothorax. But she's not unwell, and I don't see a classic pleural margin to show that there's a large pneumothorax. The other differential would be really bad bullous disease, which I've seen, which can mimic a pneumothorax. So I think the key thing here is knowing what her previous chest X-ray looked like.
Right. I'm serious. She's never had a previous X-ray. She's never been to the hospital before. But what you've just done, can I just point out to the registrars, is what you have to do. When you've got doubt in your mind, you'd have to mention both possibilities. Mm. Too many people try and punt on one and guess and go down the gurgler. So is this... You're exactly right. Is this dud lung, big bullous emphysema, unilateral, or is it a bizarre pneumothorax? And why did you say tension?
Because the mediastinum shifted to the right.
Yeah, got to be careful because she's quite rotated.
Yep.
So are you certain if it is a pneumothorax, is it under tension or isn't it?
I don't think that I could exclude it on the basis of this X-ray. I guess
is the diaphragm depressed? Yes, no, or uncertain?
I think it's a little bit depressed, and
it's lower than the right.
Yeah,
but it can be.
But I think the fact that she's not unwell makes me think that it's probably clinically not under tension. But I don't think that I could exclude it on the basis of this X-ray.
We'll go to the next slide. We've got. They weren't. I'll tell you what the clinical notes for the next scan. They decided they want to do a CT, and the clinical note for the CT said lung cysts query hydatid.
That was the clinical note. Excellent.
So does she have hydatid disease?
No.
Why not?
Because hydatid disease is typically fluid-filled cysts, and I think the classic description, I've forgotten, some sort of lily, drooping lily, there's a lily involved.
Water lily sign is one of the silly signs.
Yeah.
But the point I'm trying to make here is the term cyst, when it relates to the lung, can be confusing to many people because the term cyst means air-containing, but we also talk about fluid-containing cysts in hydatid cysts or bronchogenic cysts and urinteric cysts. So always specify what you in the chest, whether you mean an air-containing cyst or a fluid-containing cyst.
Yep.
So here's your CT scan.
Oh, didn't help. So, well, the mediastinum is shifted to the right. Is it under tension?
If the mediastinum shifted, there's tension, whether it's in those cysts or whether the tension's in the pneumothorax, whichever you're going to call it.
Okay.
But the fact the mediastinum shifted, big black means there's some sort of tension. Air under.
Yep.
Right. So is it a pneumothorax or are they big bully?
Does it matter?
Well, if it was a pneumothorax, what would you do?
You'd stick a chest drain in.
If they were bully?
Would you not? I don't know. Do you do the same?
Putting a chest drain in a bullous isn't a good idea because you end up with a bronchopleural fistula.
Okay. So I would go bullous.
All right. Trick is get out of them. Get to the bottom.
Right. So as we go down to the bottom, I can see collapsed left lower lobe on the image on the bottom left-hand corner of the screen.
Yep.
And then as we go down lower, I don't see any of those septations like I do in the superior portion. So
at the bottom, it looks like you're below all the lung, therefore...
Therefore, I think that's tension pneumothorax then.
It's a tension pneumothorax. And
so she's
they're
got
just
both.
pleural adhesions.
Adhesions.
So these patients had some sort of disease in the past.
Yep.
Anyway, unfortunately, It was called bullous emphysema.
Yeah, I can imagine it would be. I reckon I would have called it that.
She wasn't unwell. She was sent home, and the next slide, oops.
Oh, is that her next slide?
She came back to outpatient a couple of weeks later, and she was fine again. She does have some cysts in her lung, but she got away with it.
Oh, wow.
Yeah, so the human body is remarkably resilient.
So you're saying that was all just naturally reabsorbed?
Yep.
Wow. I didn't know the body could do that.
The body's remarkable.
Yeah, okay, cool.
So I wouldn't recommend you ignore most tension pneumothoraces, but this one got away.
How certain are you, Bob, that it's definitely not bullous disease? Now that you've seen that it's resolved.
I've scanned through the CT. It's fairly clear on the CT scan. I'll go back to the previous slide. And if you look at the top image, she's got what looks like normal compressed lung on that top left image.
Yep.
And the top two images, she's got normal lung, and they're just pleural adhesions.
Okay. Yep.
So the lung, she's just got collapsed lung and a big pneumothorax and a few confusing adhesions.
Yeah. Okay. Cool.
But looking at it in 3D, in multiple planes, I had no concern that it was anything but that real.
Cool.
Okay, next case.
Oh, right. So
72-year-old lady, routine chest X-ray.
Okay. So frontal chest radiograph in a 72-year-old female demonstrates a triangular density projected through the cardiomediastinal contour with loss of definition of the medial aspect of the left hemidiaphragm associated with volume loss of the left lung of the left hemithorax compared to the right side. Changes are associated with some patchy opacities in the apices, more so on the right than the left. I don't see any surgical clips, and I think based on this chest X-ray, the breast contours are symmetric. No pleural effusions, no pneumothorax, and I don't see anything within the bones. So I think there's left lower lobe collapse because of the triangular opacity and the loss of lung volume on the left. In an adult female patient, the causes of a left lower lobe collapse, if this is a new finding, then I'd be concerned about a central obstructive lesion such as a bronchogenic carcinoma. Is there a history of aspiration or some sort of foreign body that's caused the obstruction? Other causes, if it's a routine X-ray and she hasn't had any recent surgery, then I don't think it's related to, a collapse due to splinting or whatever, due to a post-surgical status, and that hasn't been given in the history. So I'd be concerned about, I think my diagnosis of exclusion here is a central obstruction with left lower lobe collapse as a result.
Sorry, it's been unchanged for 4 years.
Unchanged for 4 years, okay.
PET scan she had for another reason showed no abnormality there. So what sort of things would you be thinking about now?
Well, so is there something in the medius? Well, so the things that perplex me about that is that you're saying that there's no lung abnormality on a previous CT chest, so this isn't left.
No, it looks identical to this. No, you're quite sorry. I'm not trying to confuse you.
Yeah.
I fully agree with you. She does have left lower lobe collapse.
Sorry. Yeah. Okay.
Right.
Okay.
No, she does have left lower lobe collapse.
Yep.
And the reason I put it in there, not to show you the collapsed lower lobe, but to show you the hyperinflated left upper lobe, which gives you a small black hemithorax.
Yep. Okay.
But so my question to you about the left lower lobe collapse is, what are the benign causes of long-term lower lobe collapse?
So stricture, bronchial stricture for whatever reason, be it iatrogenic or chronic inflammation.
So tell me some causes of bronchial strictures from chronic inflammation.
Aspiration, I think, although this is not a typical distribution, you'd normally want to see that in the right lower lobe rather than the left lower lobe. TB, I think, can probably cause bronchial stricture. Previous intervention that's, I don't know whether she's had some sort of multiple bronchoscopes for whatever reason, and I think you can cause no iatrogenic. Bronchiectasis more typically causes dilatation, but I think there is a degree of bronchial stricture formation, but it tends to be more of the distal, smaller airways rather than the central airways.
This lady was lucky enough to have cryptococcal strictures of her larynx and her left main bronchus.
Oh, I would never get that in a million years.
Never get that. So you're never going to get the cause of these things. This was a benign stricture of the left lower lobe bronchus.
Okay, cool.
Okay, next slide.
Yep.
Right. So you've gone through the 4 basic, what I call Harlequin X-rays, where one's black and so they've either got a big black or a small black or a big white or a small white hemithorax. And the trick for the registrars is which side is abnormal. And the ones I've shown you, it's all been fairly easy so far. So is the abnormal hemithorax too black or too white? Is there a size discrepancy? Is it too big or too small? How much or where's the mediastinum gone? And is it pushed away or is it pulled towards? Or is there volume loss or is there a mass effect? Where's the diaphragm? And is the underlying lung normal? Can you see any evidence of pleural abnormality, chest wall abnormality, or is the patient rotated will also give you a Harlequin appearance? Next slide. All right. So here are the options: big black, big white, small white. Next.
Yep.
Big black means air trapping in something, either a tension pneumothorax or big bully or bronchial obstruction or bad lung that's air trapping. Next. Small black means you've got a small lung that's overinflated. So either you've had a lobar resection, you've got a lobar collapse and the rest of the lung's hyperinflated. You've got a hypoplastic lung that's hyperinflated, or a Swire-James lung. Again, it's a small lung that's hyperinflated. Mm-hmm. Next. Big white is pleural fluid or a huge mass. Next. Small white, lung collapse, lobar collapse, lung resection and lung hypoplasia or no lung present. So you've got a small or absent lung, gives you a small white hemithorax. Next. And these ones are difficult. If it's one side's whiter than the other, is it a technical? Theoretically, heel effect can do it, but I've never seen it. Grid cutoff can certainly do it. Yep. Patient rotation commonly does it. And then chest wall abnormalities, pleural abnormalities, lung abnormalities, or any of the other things we discussed previously, for all the others can have normal size hemithoraces. So that's the basic principles. Mm-hmm. So let's go again, Nat.
All right.
See if you can do case 5. I kid you not. These are the clinical notes pre-op. They come from the cardiothoracic unit. They've been worked up elsewhere. I had to report this with nothing else.
Of course you did. I don't disbelieve you. All right, so 2 views of the chest in an adult male patient demonstrate a pacification of the left hemidiaphragm associated with loss of lung volume, which is characterised by mediastinal shift to the left and crowding of the ribs. The ribs, particularly the first, second and third ribs, appear quite deformed. Not just that they're crowded, but their actual ribs themselves are very deformed in nature. I don't convincingly see surgical clips. The right lung is hyperexpanded. There's no effusions. There's no pneumothorax. Now, you've given me a lateral.
Ignore it. It doesn't help you.
Doesn't help me? Excellent. I hate the lateral. Now, I'm interested by the chest wall, I have to say, because now that I look at it more, I don't think it's just the ribs that look weird. I think the clavicle doesn't look right either. And the bits of the scapula that I can see look relatively normal. And the spine, I'm now looking at the spinal column because I'm wondering if there's some sort of chest wall deformity, musculoskeletal abnormality, which is this patient's been like this forever for whatever for a congenital reason. I don't convincingly see a vertebral body anomaly, but
I wouldn't worry too much about the skeleton. It's not going to help you.
Not going to help me. All right. So I think there's loss of left lung volume. The question is whether this is iatrogenic or
it's not iatrogenic.
Okay, all right. So is it a congenital process? Has this person always looked like this would be my first question.
So what are you postulating?
Or some sort of childhood lung injury or trauma in the past that's led to this sort of deformity, or any cause of chronic left lung collapse.
Right. So keeping it simple, what are the big options? He's got a very small left hemithorax.
It's either
never had a lung,
been
resected,
yeah,
or it totally collapsed.
Yeah.
But whichever one, it's been a long, long time because the right lung is markedly hyperinflated.
Correct. Yep.
What do you think of his left main bronchus?
Oh, can I see it? I can see the right main bronchus. I can't convince myself that I can see it, to be honest.
Right. So you've got the heart's way over against the left chest wall because you certainly can't see any. That right heart border is way to the left of the spine.
Yep.
So there's been no aerated lung in the left hemithorax for a long, long time.
Yep.
All right. So this is a congenitally absent left lung.
Okay.
So I've got an easy question for you, Nat.
Yeah.
Which lung do you think is abnormal?
Well, they both are.
No. Let's try that again.
No, hold on.
How many lungs?
No, he's got one lung, so that means.
Which lung do you think is abnormal?
Well, if you've only got one lung left over, then the right one, isn't it? Is that what?
Good. Yeah, well, this is, guys, you just listen to the examiner, just hear what they say, answer the question. If you've only got one lung, it's likely to be the right lung that's abnormal.
Okay, so why is it abnormal?
Would you like to explain to your registrars where your review areas are?
Okay, so for a standard chest x-ray, my review areas are the lung apices, and that's just because I have missed a 5 centimetre lung cancer in the left lung apex. I review the retrocardiac space, so looking through the heart, and on the lateral x-ray looking posteriorly over the lower vertebral column. The area of lung that is projected over where you'd expect the liver, spleen and stomach to be, because the lung goes all the way down to... You
can actually see how far it goes down in this guy. You can see, if you look carefully, you can see these pulmonary vessels way down below the liver.
And that's a really good place to hide.
And I've missed a 5 centimetre cancer down there.
Yep. And then, of course, the muscle, like the skeleton, is another check area for me, because I think sometimes we all get carried away with looking at the heart and the lungs that we don't look at everything else.
With respect to the review areas, why are they review areas?
Because this is where I think radiologists have lower sensitivity, number one, and they're areas where big things can hide. Because there's so many things that can distract you within those regions.
Now, where would you add as a review area for a person who's only got one lung?
For a person who's only got one lung, the review area would be the area which is obscured by density because you no longer have a lung there. So is that where you're getting at? I'm not sure.
No. Not worried about the left side. I'm worried about he's only got one lung. It's the right one. Yep. Your review areas are the apices behind the heart, under the diaphragm, where you've got overlying structures.
Yep. So over the spine would be
right. So why don't you review the spine over the spine and tell me where you can.
So on the frontal chest radiograph, there's over. Hold on. 1, 2, 3, 4, 5, 6, 7, 8. Sort of between the 8th and 9th. Vertebral body, there's this increased density, which I initially had dismissed as being the right hilar region, but actually that doesn't make sense because it's quite low, and I can see the right main bronchus going towards that region, but then there's this increased density there, and on the lateral projection, I think it's probably, I think it's the ovoid region located centrally within the lateral x-ray.
I think it's very hard to see on the lateral x-ray.
Okay.
But if you go to the next slide,
Do we?
You'll find
Oh.
you've now missed a 5 centimetre lung cancer
Thanks.
in the solitary lung.
Oh, God. Wow. That's sobering.
Right. So, yeah, that density is real.
Excellent. Where is it on the lateral, Bob?
I can't be certain. It's got to be just in front of the vertebral body, but I seriously can't see it clearly on the lateral.
Okay. All right. Wow.
Life's like.
Yeah, that's not fun. Did you have a previous for comparison? So was that density?
I just reported this. It was pre-op cardiac thoracic, so I thought he had left hilar lung cancer.
Yeah.
With collapse of his left lung. I didn't know he didn't have a left lung.
Wow.
So I just reported it as a central lung, probably a central lesion obstructing his left main bronchus.
Yeah. But as you say, the changes, those rib changes, those chest wall changes are quite chronic, right? Aren't they?
Oh, look, I got it wrong. Put me in peer review.
Oh, God. Can we go back one? Oh, all right. So, 18-year-old. Well, another pre-op. Excellent.
I kid you not. This is X-ray number 1 at the Austin.
Of course it is.
And the X-ray images haven't been uploaded.
Oh, of course they haven't. Okay. 2 views of the chest in an 18-year-old man for preoperative assessment demonstrates abnormality of the left hemithorax, characterized by a mass that has a well-circumscribed superior margin and a poorly defined lateral and inferior margin with associated mass effect with displacement of the heart to the right. The right lung looks normal and there is no right-sided pleural effusion. I'm uncertain about the left side. No pneumothorax. And the bones and musculoskeletal structures are otherwise unremarkable. So there's a large mass which is within the left hemithorax. Now, the question is, where is it? So initially when I saw the frontal chest x-ray and that very well circumscribed superior margin, I was thinking that this was maybe opacification of the left lower lobe, but the morphology looks unusual on the lateral projection. That's not what I expect a left lower lobe consolidation or process to look like.
Not the line of the oblique fissure.
It's not the correct orientation of the oblique fissure. So I don't think it's a pulmonary process. So then if it's not a pulmonary process, then it'd have to be pleural or mediastinal. I don't think it's...
Or one more option, 2 more options.
Pleural, mediastinal, chest wall.
Right. Or even from below the diaphragm coming
up. Yeah. Yeah, that's true. Although I don't think so, because I think who knows? Yeah. But yeah.
All right, I'm just saying there are other options.
Yeah. Mm-hmm.
So of those 4, which would you go for? Pleural, mediastinal, chest wall?
I'd go mediastinal. I'm not sure why I've put that number 1. So why would I say mediastinal? So I can't see the left heart border well on the frontal chest x-ray. So whatever this is, it's growing next to the left heart. So...
But if you look at the lateral, you can only see one diaphragm. So this lesion goes from front to back in the lower left hemithorax. So it doesn't help you one way. This could be pleural.
Could be anywhere.
This could be even pulmonary. It could be mediastinal. You can't tell. Chest wall.
Yep. Yep.
Now, you said the mediastinum was displaced to the right.
Yep. Yep.
What about the trachea?
The trachea is displaced to the right too, which is weird because...
which part of the trachea is displaced?
All of it. So that's weird. So initially when you asked the question, the first thing I did was look at the rotation of the film because I thought you were trying to lead me to the fact that maybe the mediastinum isn't displaced. But it's a well-centered chest x-ray on the frontal. So that means that whole, like the trachea from basically the superior portion to its bifurcation, the whole thing is displaced, which is weird because the opacity, it doesn't correlate to where the opacity is. the opacity stops at the level of like the fifth vertebral body. So then my question is
Posteriorly. What about on the lateral view?
On the lateral view, it stops at the level of kind of the manubrium, I think.
Yeah, which is the thoracic inlet.
Yeah. So
now you said the whole trachea is deviated.
Yeah.
For the benefit of the registrars, what are the parts of the trachea?
Oh, crumbs, now you're pushing me.
No, it's simple.
The superior bit, the middle bit, and the end bit.
There's a bit above the manubrium and the bit below the manubrium. The bit above the manubrium is called the
superior trachea.
Stick your finger on your sternal notch.
Sorry?
What's above that?
Sorry?
What's above your sternal notch?
Above my sternal notch is my, well, now hold on, you lost me, Bob.
Your neck and your head. It's the cervical portion.
The cervical portion, there you go.
So the cervical trachea is displaced, not just the mediastinal trachea.
Yes. Okay.
So what you should be telling is, despite you can see a huge mass in the chest,
it's probably
also
going up into the neck, into the base
a mass
of
in the neck.
Yeah.
So given that you're a pathologist,
oh yeah,
tell me about cervicothoracic masses. What masses cross anatomic boundaries like that?
Processes that involve lymph nodes.
Good. So massive lymphadenopathy can do it. Yep.
Processes that involve, I was going to say thymic tissue, but that's one huge thymic mass if ever I saw one. But certainly thymic tissue can basically occur anywhere from neck down into the superior mediastinum.
Yep, so that's valid. It could be thymic.
Or thyroid, I guess, as well. But, again, that would
thyroid can certainly go neck and chest. Never seen a thyroid down in the left costophrenic sulcus, but you never know.
Yep, you never know. Some sort of vascular process could cross over that boundary. So abnormalities involving the vessels and the nerves. So I've never seen it, but I'm just sort of based on...
Neurogenic tumours certainly can cross it from the neck into the chest. And vascular lesions, not only aneurysms, but hemangiomas and lymphangiomas, certainly what we call cystic hygromas, commonly were in the neck and the chest. Yep. So you've got a mass in the neck and the mass in the chest, and the mass in the chest is massive.
Yes.
Now, when you hear hoofbeats, what should you say?
Horse.
If you go to the next slide.
Oh, God, am I so scared too? Oh, my God.
When you hear hoofbeats and you see stripes, what should you say?
Zebra.
Zebra, good.
Wow. So can I just go back one? I'll just go back to the chest x-ray. Because I was going to say that for such a large thing, it's dense, but it's not super. Am I on the wrong track here? Given that, am I cheating now that I've seen this X-ray? But CT.
I think you're cheating because you're seeing it, but you're right. It's not super dense.
It's not super dense.
It's hard to be certain, but you've got to try and say, look how well you can see the left posterior ribs compared to the right ribs behind the liver.
Yes.
Right. And so it's a well-penetrated, a skinny bloke, and you can see it, but it's one of those things when you get a fat-containing mass.
Yeah.
Now, that's what you haven't actually said, but I assume you've worked out that looks like fat on the X-ray.
Yeah. Wow.
Yeah.
So is that?
So now what are you thinking?
So it's a fat-containing lesion that transgresses multiple compartments. And it's got some soft tissue components within it and no associated calcification. And it seems in the neck, it looks like it's what's infiltrating between the vessels. I'm not sure whether there's a vascular component to this thing as well, particularly on that single coronal image of the neck. So fat-containing lesions, I would be thinking a lipoma / liposarcoma.
Yep.
Thymic tissue can contain fat. Thymic masses, can you get a thymolipoma? Thymolipo. Oh,
This is a typical appearance of a thymolipoma. They're frequently quite large. They always have this sort of zebra-like appearance, as I call it, stripes in it.
Yeah. Okay.
And they usually don't go into the neck.
Right.
And the interesting thing about this is that fat component in the neck looked like it was confined to the left lobe of thyroid.
Okay.
And there have been 3 case reports that I've been able to find of thymolipomas associated with thyroglipomas.
Oh, my God.
One guy also had a pharyngeal lipoma that he could regurgitate. It would dangle, literally, there was a beautiful image from 1955. It would dangle out his mouth by 5 centimetres. But he had to swallow it before he could breathe.
Rubbish. Are you telling the truth?
I'm telling you the truth.
I don't
believe it. And he had a thymolipoma and a thyroglipoma.
Wow. That is
the thymolipoma.
That is impressive. That's
big mass.
Yeah. Nice.
Okay. And next smiling face.
Did they resect all this?
Yeah, it was resected.
I'd imagine they'd have a high recurrence.
I don't think it's a particularly difficult operation, other than it's a lot of stuff to get out.
Yeah. I feel like a new man. All right. 2 views of the chest in an adult male patient who's increasingly short of breath. There are surgical clips projected over the right lower zone, or actually, yes, right lower zone.
Yep.
There's opacification of the right lung with loss of right lung volume. There's blunting of the left costophrenic angle in keeping with a small to moderate sized effusion. And it's interesting, I can see air bronchograms centrally within this opacification on the right. And
the mediastinum?
The mediastinum, I think, is shifted to the right. So I think there's loss of lung volume. So I think there's mediastinal shift to the right.
But there's a lot of loss of lung volume. Those right ribs are very crowded. The trachea is way over to the right.
Right, yep.
It's hard to be certain where the right heart border is, but looking at where the right main bronchus and where those air bronchograms are, the heart's probably way over there.
Yeah. Now, I'm just looking at the lateral, and I don't know because of the other case, but I think I'm seeing something ovoid in the infrahilar region, but I'm not sure if I'm now making it up.
I would ignore it.
Okay, good. Okay, excellent. All
because there's no aerated lung on the right other than those air bronchograms.
Yep.
And so whatever you're seeing is probably on the left.
Yeah, that's what I mean. Are you trying to show me another left?
No, ignore the left.
Okay.
There's a left pleural fluid. No.
Nothing else.
I want you to tell me what you think is going on the right.
Okay, so the patient's had previous surgery, and there's the right posterior 1, 2, 3, 4, 5, 6, 7th rib is resected, or there's a
Yep.
So they've had some previous lung surgery, and I suspect based on the clips, it's difficult, but I'm imagining it's the right middle lobe that's gone, but I'm not 100% certain. And
none of the lobes have been removed.
None of the lobes have been removed. Excellent.
Nope.
Okay. So the curious thing then is that I can see the air bronchograms within the right lower lobe bronchus, and I think that's right middle lobe or right upper lobe?
I think it's right upper lobe because it looks like it's coming off the right main bronchus.
Yeah. So I can see, and then beyond that, I don't see that. That's unusual because really what we're proposing is a right lung collapse, but I would expect there to be a more centrally obstructing lesion to result in this degree of loss of lung volume. This is what's confusing me.
But you've got air bronchogram, so it's highly unlikely you've got a central obstructing lesion.
That's right, exactly. So what's causing this degree of loss of lung volume without loss of lung, without a central obstruction? That's what I don't quite understand.
So what do air bronchograms mean?
Air bronchograms mean there's air within a lumen, and then around the lumen is a different density. So in this instance, it could be cells, it could be fluid, it could be, wouldn't be bone or calcium, but basically you're seeing the lumen of the bronchus outlined with air, surrounded by structures that no longer contain air.
That's actually better. It's surrounded by lung that no longer contains air is correct.
Yep.
That doesn't mean the alveoli are full of
stuff.
anything.
Yeah. So it could be collapsed around it. Yep.
All right.
I'm not sure what the cause is. Is this chronic?
Next slide.
Oh, now you're going to tell me. Okay. Oh.
There's a series of X-rays over a year.
Over a year. Okay, so looking at the initial X-ray, so there was loss of lung volume on that right side, and what you don't appreciate is that there's pleural thickening going up to the right lung apex, and there's all these sort of rounded densities projected through the right, mid and lower zone. And as we come across the course...
So what are you thinking there?
So some sort of pleural process.
So you describe rounded densities in the pleural space and loss of volume. What might that be?
TB until proven otherwise.
No. Try again.
Previous trauma.
No.
I wanted to say asbestos, like a mesothelioma, but I don't see evidence of asbestos plaques elsewhere.
You don't have to have asbestos exposure to get a mesothelioma. This was a mesothelioma. He has had that surgical clips were. So he's had a fair bit of the tumour resected.
Right.
Then what have they done?
They've resected it, and then over the course of the X-rays, has he had radiotherapy?
He's had whole lung radiotherapy, effectively whole pleural radiotherapy.
Yeah.
Right. So the lungs just got smaller and smaller and smaller.
Yep.
So this is another cause of a small white lung is fibrosis.
Wow.
So the airways are all patent, but the alveoli don't contain any air.
Yeah.
So as a CT shows, he's got air bronchograms going all the way out to the chest wall just about.
So I was right to be confused.
Yeah. All right. So another cause of a small white lung.
Nice. Wow. So, but I mean, that wouldn't, like mesothelioma without asbestos, that's without calcified pleural plaques, that'd be pretty uncommon, wouldn't it?
Not rare. By no means rare.
Oh, okay. I've learned
if I had to guess 20, 30%.
That high?
Yeah, I think I'm guessing, but that order of magnitude, we've seen quite a lot of them.
Okay. All right. Oy. Okay. So, erect mobile film in a 79-year-old man who presents with left chest pain. So, this patient has sternotomy wires and surgical clips and mechanical valve replacement. He's got a dual chamber pacemaker with the leads intact. He's got a right internal jugular and CVC line with the tip projected over at the expected location, the cava atrial junction, and he's got a lot of ECG leads over the top, but I don't see any other new leads. There's asymmetric density of the left lung with respect to the right, with the left lung appearing of increased density compared to the right side. I see. Are
you sure the right's not too black?
Am I sure? So it's an erect mobile film. And it's fairly well centered. So I'm pretty comfortable that I think the abnormality is on the left, but I take the point that the lung volumes are relatively preserved and symmetric. So it is that question of which side is abnormal. Why do I say I think the left side? I just get the sense that the left side of the patient just looks denser, actually. If I look at the soft tissues, is this some sort of technical problem? Is there some sort of grid-related issue here that's causing the asymmetry? Because I don't think it's just the lung. I think it's the whole left side of the patient looks. Actually, so there's old posterior rib fractures. Well, I think they're.
Ignore them. I don't know if they're real or not.
Okay.
No, you're quite right. It looks like there are. Yep.
And then I don't know if I'm making stuff up, but there's some sort of lucencies projected over the pacemaker. And there's some lucencies in the soft tissue. Has people been intervening on this patient? Has someone done something to this patient recently? That's my first question.
Why are you asking that? Sorry?
Because, I don't know if I'm making it up, but between the above the coracoid process of the left scapula, there's, I think, what look like at least 2 large lucencies.
That's good observation.
Which I think are.
Is that a pacemaker inserted?
Oh, the pacemaker's new.
3 days ago.
Oh, the pacemaker's new. Ha ha. Okay, hold on. So then, assuming that the asymmetric density is real, and is this a large chest wall hematoma or something? Something in front of the chest related to the pacemaker.
Now, you said the pacemaker leads were intact.
Well,
funny term.
Well, as in they're not, you know how they break and they disconnected and stuff?
Well,
that's what I mean by
Where
intact.
are pacemaker leads?
So that pacemaker is not how I would normally see it. And initially I thought it was projectional, that maybe the patient's lying funny. But usually when you look at pacemakers, you can see the electronics on FUS, whereas I'm not seeing them. And you normally can actually trace the leads down into the pacemaker proper, and I can't. So that pacemaker's been put in at a funny angle, or
correct, or it's in a funny angle
or it's
now.
in a funny angle, yeah. So
but where are the tip of the leads?
Which tip? The intracardiac tips?
Yep.
They should be. Oh, now you're testing me. One's in the right atrium, and the other one is probably in the coronary sinus.
No, it's probably in the right ventricle. It's probably all right.
It's all right? Okay.
So let's assume the right ventricular one's all right, but where's the tip of the atrial lead?
Oh, it's quite low. Are you trying to say?
Very low.
Yeah.
Now go to the next slide and you'll see what it looked like when they first put it in.
Oh. Oh, now hold on.
So I've got the x-rays. Sorry, the x-ray on the right is the first one.
Yep. So something's happened to that pacemaker. So the chest wall component is in a completely different position to the initial chest x-ray, and the leads are now sitting, that right atrial lead
the atrial lead is flipped around. It was doing a U-turn. It's now going straight down.
Yeah. So
you have the next slide now. I mean, they knew what his problem was. They could see it. It took them 3 days to do anything about it.
Oh, that's not good. Oh, wow.
So as a CT angio, 3 days afterwards, he got a huge hematoma. He's actively bleeding.
Yeah. Golly, that's not good.
So that was just one of the chest wall causes of one of these Harlequin x-rays.
Nice.
Okay, next smiling face.
Okay. Frontal chest radiograph in a 69-year-old male, performed for the purposes of checking the nasogastric tube, which I think is in the right place. So it's quite a rotated film, is my first comment. And I think he's probably rotated with the left chest wall more anterior than the right side. There's asymmetric density in the lungs, with the left lung appearing more dense than the right, but you're going to ask me the question, which is the abnormal side, because the lung volumes look relatively symmetric. The heart size and cardiomediastinal contours look okay, look within normal limits for an AP erect film, and there might be some minor blunting of that right costophrenic angle, no pneumothorax. So the question is whether the increased density, the asymmetry in density is due to the rotation of the patient, which is what I'd be postulating as a potential first port of call.
Good. Excellent. Go to the next slide.
So
that was an X-ray an hour earlier when they first put his nasogastric tube in.
Yeah.
And he had no lung abnormality, but they did put the nasogastric tube in his right lower lobe bronch.
I'm not laughing.
And the X-ray the following day was totally normal also,
yeah,
so I'm sure it's just due to rotation.
Yeah, cool. And also I think that again, like the last one, I think the soft tissues on the left look more dense as well compared to the right.
They always do when you're rotated because you're going through
more tissue.
The paraspinal soft tissues and the lateral soft tissues are projected over the lung instead of the medial tip tissues.
Yeah, cool. Next. Excellent. Okay, so 50-year-old female. So frontal chest radiograph in a 50-year-old female pre-operative assessment and cervical spine surgery. So
this is the truth. She's come in for she's got degenerative canal stenosis of the cervical spine. This is just a routine pre-op chest X-ray.
So, I don't know whether it's the JPEG, but I'm not getting a distinct Harlequin feel to this X-ray as I look at it. I think maybe the right side is slightly denser than the left but I'd be a little bit hedging my bets, and I don't know that I would necessarily prospectively call it if you weren't telling me that there was asymmetry. I wonder whether I take that back. I do think that there's I think the left lower zone is more lucent than the contralateral right side. So I do think there is an asymmetric density, and she is a bit rotated, but not greatly rotated. I don't see any, now it's a woman, I don't see any surgical clips, but I wonder whether I'm seeing absence of a left breast shadow, or maybe I'm making...
No, I think they're both there. They're just outside the field of view.
Okay, all right. And I don't see any markings about whether this is an erect or supine film. There's some deformity of her third and fourth lateral ribs. And
Correct. I don't know what that means. Ignore it.
Okay.
Assume it's not there.
Assume it's not there. Okay. And otherwise, there's some rounded densities in the right apical region, but I think they're probably by the by. And the heart size is big, but I suspect this is probably an under-inspired AP film. She's got a scoliosis. So actually, I think scoliosis can probably cause apparent asymmetry of the projection of the lungs, particularly if there's a degree, depending on the severity of the scoliosis. I think it can have an impact on the way the lungs develop. I'm struggling here.
What do you think of the pulmonary vascularity?
Yeah, actually, I was going to comment that the central left pulmonary vessels are very prominent, actually. Initially, I thought, when I first looked at it, I thought they were actually granulomas or something, but actually I think their pulmonary vessels end on, and I think they're too big on the left. But centrally they're big, but peripherally it's quite pruned. So peripheral pruning, but asymmetric peripheral pruning. Okie doke. So pulmonary
the problem there is that you're using what I call jargon terminology again.
Yep.
Peripheral pruning, you usually use that to describe what?
So
pulmonary vessel with peripheral pruning is pulmonary hypertension.
That's right. Yeah. That's why I'm getting myself confused.
But this is not that.
That's not that. Okay. All right. So what I'm saying
is, what are we really seeing
I'm
here?
Seeing
keep it simple descriptive terms.
I'm seeing a relative. I'm not seeing the peripheral vessels well, and I'm seeing the central vessels too big, for want of a better description.
What vessels are they you're seeing that are too big, do you think?
I think they're probably pulmonary. I think they're probably pulmonary veins. And the reason I say that, does that make sense? It doesn't really make sense, actually. I take that back. I think they're probably pulmonary arteries.
That doesn't make sense either.
Unless there's a big central pulmonary embolus or something that's expanding the vessels.
How about
or aneurysms?
Paucity of vascular marking seen in a large part of the left lung.
Yes, correct.
And there are some funny nodular densities essentially which might be dilated vessels or might not be.
Okay.
And they might be pulmonary nodules or granulomas, as you call them, or there might be something else.
Yep. Oh, they're actually quite tubular. They're quite. So I've assumed that they were vessels, but they might be vessels. They might be, although I'd expected to see loss of lung volume, but they might be like bronchoceles or something within the bronchi.
That's a better thought.
And so then are you getting like a bronchial type obstruction, which results in vasoconstriction of the peripheral of the lung? Is that why you're getting that asymmetry? So definitely there is a paucity of lung markings, and I think the peripheral vessels are quite definitely hyperplastic compared to, I'm trying to find the right terminology here, but they're not as well seen as on the right side. So I do think the abnormalities.
Yeah, look at the next image.
Oh, put me out of my misery. Oh God, has that helped? Okay, so yes, I'm correct. I was on the right path, but I didn't quite. Yes, all right. So there's lucency of that left lung compared to the right lung, and
or at least the left upper lobe.
Yeah, left upper lobe, and those large tubular structures. I don't feel I'm any the wiser based on these selected images as to whether they're bronchi or vessels. My gut feeling is they're bronchi.
How would you tell?
I can't tell on the sagittal image in the middle. That's a funny shape for a vessel.
Good. That's a very funny shape for a vessel. It's a funny shape
for a vessel. So is that in a bronchus?
That's a bronchocele. You are correct.
Get something right. Oh, God.
So what's the diagnosis?
Because
a bronchocele is sort of like saying it's lobar collapse. It's not a diagnosis. It's a finding.
It's a finding. So bronchoceles can be so it's a result of proximal obstruction. So whether there's a bronchial stenosis that's then resulted in fluid accumulation in the distal portion of the vessel, and all sorts, anything can cause a bronchial obstruction, being benign or malignant processes. And in an adult patient, you'd have to exclude a malignant process. I don't know whether the fact that there's vascular pruning helps you decide whether it's acute or a chronic process. That I'm less certain about.
I can tell you it's been unchanged for 4 years.
Perfect. All right.
Since the first X-rays, we've had follow-up because of the cervical spine issues for 4 years, and the chest X-ray is unchanged.
Okay.
And no one's done anything about it.
Oh, that's not good. Benign and malignant causes of bronchial strictures resulting in bronchocele. They can be congenital as well, I think.
Yep, bronchial. That's probably the most likely. This is just a congenital bronchial atresia, except I don't know what those funny deformed ribs are all about.
Yeah.
So maybe their patients had something in the past as a child that I know nothing about.
Yeah. Okay. Cool.
Yeah, so you're right. There's something blocking the bronchus, which might be congenital, and this is a typical appearance of a bronchial atresia. Yeah. But it may also be a bronchial stricture from some previous surgery or from some other pathology we don't know anything about.
Excellent.
So they're bronchoceles and hyperlucent lung.
Nice. All right. 42-year-old female pre-op chest X-ray. All right. 2 views of the chest demonstrate increased lucency of the right hemithorax with displacement of the mediastinum to the left. There are curvilinear densities within the right lower zone with more sort of a bubbly appearance, bubbly lucencies within that right lower zone, which are of a different nature to the majority of the lucency. There's a curvilinear density projected over the left lung, left upper and mid zone, and I'm uncertain what that represents.
Where is it?
So over the left lung, I'll show you with my cursor. I'm talking about this structure here.
You don't need to use a cursor. You just need to describe it so everyone knows what you're talking about.
I'm getting tired.
You mean parallel to the left chest wall, about a centimetre in?
There we go, that one. Yeah.
So what is that line?
So I'm not certain. Initially, when I first saw it, I was concerned that that could be a pleural edge of the left lung with a pneumothorax on the left, but I think I can actually see lung markings beyond that. So I'm not sure whether that's what that represents, and it's quite it's quite thick. It's thicker than I would expect for a pleural edge. And I can see the lateral margin, and inferiorly I'm unsure where it continues. And I don't know where the medial portion is. And then on the lateral x-ray, there's another there's sort of these parallel curvilinear densities projected over the mid and upper chest, which I'm wondering if they're part of the same process. And on that lateral x-ray, I think I can actually see more convincingly a rounded lucency associated with that curvilinear density. So I'm not really sure, to be honest. I initially thought maybe it was part of the right lung coming across and that I was catching an edge.
If it was part of the right lung coming across, what would that line be called?
If it was part of it's a herniation of some sort of description. It's in the wrong place.
Where the right lung meets the left lung anteriorly.
Oh, the anterior junctional line.
That's the anterior junction line way over on
well, that's not normal.
That's the anterior junction line way over there on the left. You are correct.
That's not good.
That on the lateral image in front of the superior mediastinum, you can see that great big lucent part of the lung herniating across the midline.
Oh, wow. So this is another tension pneumothorax, is that right?
I didn't say that.
Okay. You're making me work hard here, Bob. Well, then the next differential, as we said before, would be a big bullous. So it'd be important to know if this patient has got previous chest x-rays for comparison.
Let's go back a tick.
Mm-hmm.
Which hemithorax is abnormal, do you think?
The right.
Right. And what's wrong with it?
It's too big.
It's way too big and it's way too lucent.
Yep.
Which means you've got air trapping, either in a tension pneumothorax or dud lung.
Yep.
How long's it been like that for the anterior junction line to get across there and the heart to get shoved way across? Where's the right heart border?
Well, initially I thought it was the edge that's seen along the medial inferior aspect of the right hemithorax, lateral to the, I think they're like the 8th, 9th and 10th ribs. Vertebrae, sorry. Initially I thought it was that, but now I'm less certain.
Now you've spent a bit more time looking, you think it's that structure to the left of the spine.
Yep, I do.
Which is correct.
Yep.
So the heart is shoved way across to the left of the spine. Yep. The anterior junction line's way across near the left hemithorax. So this is a chronic, massively hyperinflated right lung.
Wow. Well, then it'll be bullous then if it's chronic. You can't live with a pneumothorax like that, can you?
Next slide.
Oh, here we go. Oh, it's not even a bullous.
Nope.
Oh, God. So it's really bad emphysema of one lung. Is that what I'm looking at? Because the left lung looks normal or relatively
The left
normal.
lung is normal.
The right lung is hyperexpanded with a paucity of lung markings and destruction of the normal lung architecture. So that's emphysema.
Sort of.
Sort of. Is this that vanishing lung thing that I've never actually fully ever understood?
Don't go there.
No, good. I've never understood it.
Giant bullous disease. It's a stupid term for giant bullous emphysema.
Good. I'm glad you said that because everyone uses it and I never know quite what it means.
Unfortunately, we've had a recent case where someone was confusing vanishing lung disease with shrinking lung disease, and these silly jargon terms that I don't think help anyone.
Yeah, okay. So
how long has this been there for?
A long time.
How old's the patient?
I have to go back and check. She was 42, so not that old, seeing as I'm 43. Thank you very much.
And she's had this for 42 years. So what did you tell me it was?
What's it called? The names escape me. You need to help me, Bob.
Yeah, CCAM.
Yeah, that one.
Congenital cystic airway malformation.
Wow.
Yeah, so you don't always get congenital things in kids.
No. Crikey.
So, as I said, it's a dud lung, whatever you want to call it.
Yeah.
Grossly hyperinflated lung.
Yeah. Nice.
And that opacity you could see that you thought was the right heart border, I haven't shown you here, was actually collapsed right part of the upper lobe. So this is mostly upper lobe. It's just massively hyperinflated and compressing all the rest of a right lung.
Yeah. I thought initially.
So that's a lobar collapse you're seeing there, or part of a lobar collapse.
Wow, that's fascinating.
But it was actually part of the upper lobe just squashed down there by this huge cystic lesion.
Wow, that is fascinating. Good grief.
I thought I'd show you some easy cases.
Yeah, thanks.
So you could have studied all your life, you would never have got them right.
No.
Have you had enough, or can you cope with one more?
No, keep going. Yeah, I'm happy to keep going. If you're happy.
Yep.
Yeah, okay, cool. All right, so abdominal pain. Erect mobile film in a 41-year-old man presenting with abdominal pain.
So it came with an abdo x-ray, but this was his chest x-ray.
Okay, demonstrating asymmetry in the lung densities, with the right side appearing of increased density compared to the left. It's a relatively well-centered film. I'm going to say non-technical things here, and I'm not sure if it's because it's the projection or what, but I'm wondering if this is a technical issue. And the reason why I say that is because on the left side I can see grid lines, and on the right I can't. Good. Ah, she got one right. Unbelievable.
What are the other things you can see that make you think it's technical?
Well, I can see the label, and take that back. I think that the margins of the vessels, so the vessels look quite different. So I can see very crisp margins of the vessels on the left side, patient's left, but on the right side, those margins are very blurred. So I don't know whether that contributes to the assessment that I think it's technical. What else?
What do you think of the cone marks?
The cone marks? You mean the way... Oh, I see what you're saying. So on the left, at the edge of the film, I can see like a stripe. Is that what you're talking about?
Number one, it's not a film, it's digital.
Sorry, digital. Sorry, on the edge of the image.
They've shoved the cassette in too far. It's an AP mobile, and they've used a grid technique. They've shoved the cassette in too far behind him.
Yeah.
And so they've cut part of his chest off the image because so the X-ray tube's not lined up. But I suggest the cassette's probably not parallel to the X-ray beam, which is why you've got the grid cut off, because they've used a focused grid.
Yeah.
And so you've got grid lines on the next image. I've magged them up. My eyes aren't good enough, but you can see you've got grid lines on the left side and no grid lines on the right side.
Yes.
And the right's under it. So this is a grid cut off.
Wow. Nice. That's lovely. That's a very...
You're in charge.
Keep going.
Keep the
I'll keep going.
standard better than that.
Thanks. You used to be in charge. You should be. It's all your fault, actually. Yeah. Right back at you.
Okay. Here's a sick patient.
Yes. So, AP erect film in an 80-year-old male with cirrhosis who's been had a MET call. There's asymmetric density with the right hemithorax of increased density compared to the left side. It's a poorly rotated film, but I do think the abnormality is on the right. Changes are associated with prominence of the upper lobe pulmonary vasculature. And I'm looking for interstitial curly B lines, which I think I can see within that right lower zone.
I'm not certain I can, but you've got better eyes than I have.
Well, maybe I'm making it up.
Whereas I can see some air bronchograms in the middle.
Yes, there are air bronchograms, and there's no effusion and there's no pneumothorax. So I think this person has left ventricular failure, and I think that the reason why there's asymmetry, and I'd want to know how the patient has been cared for. So is the patient lying on one side? So is this pulmonary edema that's come down onto the dependent portion of the lung, and now they've propped the patient up to take the X-ray, and he just goes back and lies on his right side. In the acute setting, if it was a chronic process, then the differential is quite different.
No, he's acutely unwell.
Yeah. So my gut feeling is that this is probably pulmonary edema with the patient nursed on one side down. Differentials would include pneumonia with an associated left ventricular failure, or pulmonary, or another process of pulmonary airspace opacity, unilateral pulmonary airspace opacity. So pneumonia, hemorrhage, pulmonary edema, as I've described.
Good. Next image.
So
24 hours later, it went away.
Yeah, so I reckon it's all fluid.
Yep, that's just unilateral pulmonary. So it can be pulmonary pathology as well that does it.
Mm-hmm. Cool.
Fast case, I think.
Oh, nice. Okay. All right. Chest pain, unwell. So
8 o'clock Monday morning, we've got the teaching meeting. I'm in ED, and this guy, they said, got this chest X-ray. What's going on?
Okay, so frontal chest radiograph in an adult patient. Not sure if they're male or female.
He's male.
Male.
Oh, sorry, I forgot.
That's right.
He's about a 50-year-old male, something like that.
Okay. There's increased density of the left hemithorax compared to the right side, with relative preservation of the lung volumes. I'd have to say it's technically not a great X-ray. The patient is rotated, and it's somewhat underexposed on the left side. I don't think there are any effusions. I don't think there's a pneumothorax, and I think the heart size and cardiomediastinal contours are within normal limits. So unilateral increased density. I can't convincingly see an air bronchogram. So differentials for this appearance. Well, it's basically, I think the left side is abnormal. I think that it could be abnormality anywhere from chest wall through to pleura, through to lung, and out the other side. The fact that it's so uniform in density, I'm wondering whether there's a loculated effusion or something that's causing this appearance, giving this sort of very veiled appearance to this left hemithorax.
What's against an effusion?
Well, the patient is up. I think the patient is upright, and I don't see blunting of the costophrenic angle, but that might be because it's loculated. And
you can see the entire left hemidiaphragm.
Yes, but if it was loculated posteriorly, you might see the entire hemidiaphragm, wouldn't you?
Right. Is there any evidence of pleural fluid anywhere?
Well, actually, at the superior margin on that left chest wall, I wonder whether there is some apparent pleural thickening, sort of between rib 3, laterally.
Yeah, medial to the lateral part of left third rib.
Yeah, I think there's
the lungs displaced away from the chest wall. So there is some pleural fluid there. Yeah. So they thought he might have had an aortic dissection. He had tearing chest pain through to his back, and they thought it could have been aortic dissection.
So really the only part of the aorta that I see very clearly is the aortic arch.
Yep.
I don't really see the descending thoracic aorta well, but it's not a great film, so I'm not sure that I'd feel comfortable to say that it's abnormal. I'm not certain.
So they sent him round for a CT of the chest.
Mm-hmm.
I think they weren't certain if they wanted a CT angiogram, a CT pulmonary angiogram, or an aortic angiogram. But they sent. So I decided, why don't we do a non-contrast scan first, and then we'll work out what we think.
Okay. Is that next?
Yeah, you can have the rest. You can have them all together.
Oh, this is not good.
Yeah. So the first image is this non-contrast scan, and I decided he needed a CT angiogram.
Yes, I think that's a very sensible call, Bob. Wow. So that's all blood. It's bleeding from. Is it bleeding from a posterior? It's bleeding from an intercostal. So there's an aneurysm of an intercostal vessel. How did that?
You got it.
How did that happen? Did they intervene? Did someone do something to this patient?
This guy has had no trauma. He's had no intervention. He has had no surgery. He's a virgin body apart from this spontaneous ruptured intercostal artery aneurysm.
Wow. That'd be
and, of course, he's on the CT table at 8:30 in the morning with no IV line and no nurse.
A Bob special.
So Dinesh kind of went in and embolized that thing by 9 o'clock.
Wow, that is impressive. Don't we provide a great service?
Some of the guys do.
Oh, boy.
Last case. I forgot. Can you cope with one more?
Yeah. I could cope for another. I could cope for another 20, Bob.
Nah. This guy is 6 months post-op after a right upper lobectomy.
After a right upper lobectomy?
Or lung cancer. No tricks.
Okay. So frontal chest radiograph, an adult patient, demonstrating surgical clips and loss of right lung volume in keeping with the history of surgery.
Oh, I forgot to put the Harlequin here to remind you what we're talking about.
So I think there's a Harlequin between the right upper lung and the right lower lung.
The right upper lung is
relatively lucent compared to the right lower lung.
Relatively lucent compared to the rest.
Yes.
Correct.
Yeah. I think there's a relative paucity of lung markings. Well, so what am I trying to describe? So on the left side, I can see lung markings and in the way that I would normally expect to see them. And on the right, I can see one or two, and then they're quite asymmetric. But if he's had previous surgery, I'd be wondering whether it's just related to his previous surgery or whether it's real. And then there's a funny... Oh, is it just rib? There's a funny kind of density along sort of projected over the right anterior third and fourth ribs, which I don't think they're ribs, but there's sort of this increased... Oh, no, I think I'm making it up. Hold on.
You're talking about that linear opacity?
Yeah.
Is it the edge of the scapula or is it medial to that? I think it's medial.
I think it's medial. And it
looks like the pleural edge, perhaps.
Oh, yeah. It's a funny looking vertical line in the wrong place.
Correct.
I
couldn't explain that either. But explain that lucent upper right lung to me.
Well, I mean, I'd want to. So you said he's had a right upper lobectomy. So
yep.
So
it's probably not the right upper lobe.
No, it's probably a expanded right lower lobe. Is that what you're saying?
Close but no cigar. What's the other option?
Right middle lobe.
Yeah.
Huh. That's right middle lobe up there.
So sometimes when you do a right upper lobectomy, the lower apex of the lower lobe goes to the apex,
Yep.
and sometimes the middle lobe goes to the apex. Sometimes they actually do a pexy of the middle lobe to stop it going up there,
Right. Okay.
which they haven't done in this patient. So,
And
that funny linear opacity you've mentioned,
yeah.
what do you think that is? Any idea?
Some pleural adhesions. Some funny scar, but it doesn't look like surgical material.
Well, let me tell you, you reported one of his CT scans, his first post-op CT scan.
Oh, my God, don't tell me.
And it was interesting because you commented that he had some pneumonia in his right middle lobe. And a funny ovoid area of what looked like pneumonia or consolidation in his right middle lobe on that X-ray.
Okay.
Well, I'm reporting that the next study is his follow-up CT scan.
All right. Oh, God. Now, am I going into peer review, am I?
No, it's all right.
Oh, good grief. I'm never going to get that in a million years. Hold on. Wait a minute. Let me go back.
You can't see that. Don't worry. It's intermittent. It comes and goes.
Oh, my God.
So what's he got there?
He's got lung herniation.
Right.
Why? So through his
That happens.
through a surgical defect? Is that what it is?
He's had a thoracoscopic, a VATS lobectomy, and that's one of these port sites. And so he's got a lung hernia through the port site.
Wow.
Which interestingly comes and goes. And when I said you reported an earlier CT,
yeah.
He didn't have the hernia at the time of your CT, but he did have that. See the funny pleural edge in his lung?
Yeah.
He did have that. You reported as a funny area of consolidation in his right middle lobe.
Oh, so I wasn't right. Is that what you're telling me?
But don't forget the Harlequin. This is not about the hernia.
Okay. So what's happened? So there's a funny swirl at the right hilar region, or am I making that up?
Sort of.
And you
tell us about the densities of the lung. That's what we're talking about.
So
today.
the right upper zone lung, whichever lung that is, and I'm not certain. I'm assuming it's middle lobe flipped up, but I'm a bit uncertain based on the images provided. But my guess would be it's the right middle lobe that's popped up.
The way you can tell is to follow either the vessels or the bronchi. And the vessels in all the rest of the lung all belong to the lower lobe, and they don't connect to that one. And he hasn't got an upper lobe, so that must be the middle lobe.
Okay, so the right middle lobe, which is lying within the right superior chest, is hypo-attenuating compared to the remainder of the lung. So the question...
It's got small vessels and it's too black.
It's too black.
And the right middle lobe bronchus, which comes down off the bronchus intermedius under the right pulmonary artery.
It looks like it's got something in it, or is obstructed, or...
No, it's just narrowed.
It's narrowed.
Because it's gone down and twisted up the top. And it's just... And you can get torsion of the middle lobe. This isn't actually torted. It's just twisted over the right pulmonary artery. And the bronchus is narrow and he gets air trapping in it.
Wow. Nice. Wow. Don't we see good cases at the Austin?
I have to tell you, of these, 13 cases we've seen, 15 cases, I think half of them have to go into peer review.
God, Lord help me. Awesome.
So, Nat, I must say congratulations. You've passed today's tube.
Oh, thank you, Bob.
Next time we do this, we'll go to grade 1 level.
Oh, thanks. Is that a promotion?
So
is that a promotion or a demotion?
Yeah, promotion for prep.
Well, thank you, Bob. I had fun. I was a little bit scared, to be honest. But it's a wonderful set of examples of how to think about plain X-rays, which I think are really hard to read in a textbook. So I really am grateful to you, Bob, for all your work on this particular tutorial, but also all of your gems of knowledge that you share with all of us all the time. We're very privileged to have you in our department, and I'm really grateful for everything that you've done for us.